Curious about the same thing, and I remember reading about it one time, but I don't know where it is. Well, we're back, and I want to continue talking about different patterns of depression that are, again, these are not necessarily in the, I'll mention which ones are in the DSM, but they're descriptors of various sorts that are useful for various distinctions and in various kinds of research. To begin with, just recurrent pattern. Depression in particular are often seen as recurrent. That is, if you have one episode, your probability of having a second episode is about 50%. And if you have two episodes, your probability of having a third is about 70%. So for many people, depression becomes a recurrent disorder, and there are people who talk about treating recurrent depressions as kind of as chronic illnesses that require kind of lifelong attention and follow-up and treatment. Seasonal pattern is a descriptor that's in the DSM. You can have seasonal pattern, unipolar or bipolar disorders. The idea of a seasonal pattern is that the depressive episodes, and let's talk about the more common seasonal pattern is depression. Depressive episodes that occur regularly on an annual basis, and typically they're fall onsets of depression and spring remissions. So the episode starts in the fall and remits in the spring. I'll talk later about the fact that there are some ideas about the nature of depression, that it has to do with biological clocks of various sorts and response to annual and daily cycles of time and weather, light. Seasonal pattern does seem to have to do with exposure to light. It varies in frequency with latitude. The farther north you live, the more likely seasonal pattern disorders, the more frequently they occur. We don't see it very often in Houston or farther south. You don't see it very often, but farther north you do. I had a graduate student from Denmark, and she said it's a relatively new diagnosis, and almost as if it's been discovered in the U.S. the last couple decades. But she said it's been recognized in Denmark and referred to as spring disease. And you went to your doctor who would diagnose spring disease, and they would recommend a sun lamp. Indeed, light is now one of the current treatments for seasonal affective disorder, and very intense lights are used, and the idea is that you sit in the morning under this light for an hour or two, and it tends to almost reset your clock, if you will, your biological clock, to overcome the seasonal disorder. The light therapy is a very interesting phenomena. It's somewhat problematic. Some people have difficulty tolerating it. It has side effects. It produces nausea in some people, and other than that, it's just boring to sit for a long period of time under a light. So in response to that, what they've done is to produce more and more intense lights, and you get a very clear dose effect. That is, people respond more to a higher dose of light. So you can get the same effect with a higher intensity light in less time. So they've now gone to these very high intensity lights and reduced the time that you need to sit under them for treatment. Again, this has been something that's kind of newly recognized in the U.S. And kind of American psychiatry, but it's clearly been around for a long time, and people also have done studies. If you look at people who don't meet the criteria for a seasonal pattern, to meet the criteria you have to have several years in a row where you have a regular every fall episode that remits in the spring. Incidentally, manic episodes are more likely to, you can have seasonal pattern manic episodes. They're typical summer episodes. They start in the spring and people get over them in the fall. If you look at people who have non-seasonal affective disorders, mood disorders, and you if you keep track over many people, say you take 100 patients or 1,000 patients, you will find that there's a seasonal pattern. That is, that episodes may start any time of the year, but there's a higher incidence than you would expect if it was just random of fall onsets in non-seasonal pattern. Even if you don't have it regularly in the fall, you're more likely to have one that starts in the fall. So again, there's something about the seasonal, or our response to the seasons and to light that affects other depressions as well. I talked to was doing a screening interview for some of our depression groups, and talked to a woman who told me that she had for the last 8 or 10 years, she'd had an episode of depression every fall, and that it seemed to remit in the spring. But this year it had been worse, and instead of what she used to do, which was sit out in her backyard and read in the spring, she felt so depressed that she just stayed in the house with the blinds pulled down, and she hadn't remitted. She hadn't overcome her depression, and this was on into the summer, and she was still feeling depressed. And she'd never heard of seasonal affective disorder, and when I talked to her about it, it seemed to be fairly clear that she had probably helped herself remit by spending time outside in the sunlight reading, and had prevented that remission in this particular year because she said she didn't feel like going outside, so she had stayed essentially in the dark. So I referred her for workup and psychiatric workup and light therapy. Postpartum depression, something that you hear about in the news. It's the idea of depressions developing after giving birth. Some people make distinctions. There's postpartum blues, which are very common and may simply be the reaction to the stress of birth of a child. There are postpartum depressions, which are more full-blown clinical depressions and last for longer periods of time. It's only the best predictor of postpartum depression is prepartum depression. A student of mine did a dissertation on this topic and has continued for a number of years to study postpartum depression. And the finding in that study was that the depression scale scores given prior to a couple months before giving birth tended to predict who responded with greater depression after giving birth. And there are psychotic depressions as well, psychotic reactions. These are relatively rare, but we had the case in the news a few years ago of Andrea Yates, who's probably suffering from a psychotic postpartum depression. The issue has been whether postpartum depressions really are a different kind of biologically caused depression, and that was sort of the assumption for many years. But the diagnostic system has, other than being sort of a tag that where you say, yes, this occurred after shortly after giving birth to a child, the diagnostic system doesn't recognize it as a different type of biological disorder, and many people feel that it's simply a frequent time when people may become depressed, when women may become depressed, because it's a very stressful life event and has many stressing components to it. Taking care of a newborn is joyful for most people, but also a lot of effort. Becoming a parent is a major life event and can be considered a stressor. Rapid cycling is another course description. In the diagnostic, in the DSM, rapid cycling means that you have at least four episodes within a 12-month period, so that you're going in and out. A typical depressive episode lasts 4 months. 6 months is not unusual for a depressive episode that may naturally remit after that period of time. Manic episodes tend to be shorter than that, measurable more in days to weeks rather than months. Rapid cycling, again, means that it may be a more severe form of the disorder where you go in and out of the episodes more frequently. There are also people who have hyper-rapid cycling, where they go in and out of episodes within days to weeks. They may be in a depressive episode in the morning and in a manic episode in the afternoon on the same day. And there have been studies of, this is again fairly rare, but there have been studies of individuals with hyper-rapid cycling in hospitals. Talk a little bit about the epidemiology of the disorder. This is the 1 month prevalence, that is, in any given month, what proportion of the population meets criteria for these disorders. All mood disorders, about 5%. Major depressive episodes, about a little over 2%. Manic episodes, under 0.5%, 0.4. Dysthymia, about 3% of the population. This is lifetime prevalence over the course of the lifetime, what percentage of people are likely to have the disorder. This is one set of figures from NIMH. I've seen higher figures than this recently, and we'll get into the question of whether or not depression may be increasing. Just to talk about with the sex ratio, tends to be more frequent in women than in men. Again, different studies suggesting different ratios from 1.5 on up to 3 to 1. And bipolar more frequently. I've seen in some places suggestions that there are really no differences in incidence between men and women, but some studies show a slightly more frequent in women than in men. Why might that be? Why is depression more frequent in women? Certainly this difference doesn't occur until puberty. If you look at depression scores in children, they tend to be equivalent until you get into early teenage years, and where they start to increase for girls. There are some suggestions that there may be biological components, but if there are, they're not clearly known or identified. There may be cultural differences in the nature of the expression of depression, where women are more likely to get the diagnosis of depression. Men are more likely to get a diagnosis of alcoholism or other drug abuse, and the two disorders to some extent tend to run in the same families, so that it may be that males are expressing their depression, are medicating their depression with alcohol, whereas women are expressing their distress as depression. There are suggestions of differences in socialization styles. We'll talk later about attributional style. Women are more likely to blame themselves for negative events and not take credit for positive events. There have been studies of children by Carol Dweck, who's a developmental psychologist. She found that in observations of classrooms, that if boys fail at some task, boys are more likely by either male or female teachers to be told, you just keep at it, try again, you can do it. And thus they're being given an effort attribution, you can do it if you apply more effort. Girls are more likely to be told, maybe that's too difficult for you, let's try something easier. And therefore, the communication is that you don't have the ability, or it's a failure due to ability. And the suggestion is that this kind of socialization may make women more prone to viewing themselves as helpless in the face of distressing events. Susan Nolan Hoeksema has a theory about ruminative style, she refers to it as. And the idea is that some people are more prone to depression. People who are more prone to depression tend to have a ruminative style. That is, when something bad happens, they tend to ruminate about it, go over it, and try to figure out why it happened, but that the rumination is often sort of unproductive worrying. And having a ruminative style seems to put you at risk for depression. If something bad happens and you tend to be a ruminator, you are more likely to develop depression. Women are more likely to have a ruminative style than men. And this is, again, a continuous variable, the degree to which you tend to ruminate about things. And women are more likely to have it. It always reminds me, if you're familiar with the cartoon, the Kathy cartoon. There was a cartoon one time in which on whatever it was supposed to be a Friday date, she and her boyfriend had said something to one another, and both had the thought, I wonder what she meant by that, I wonder what he meant by that. And Kathy says, I wonder what he meant by that, and then discusses it with her mother, and then talks about it with her girlfriend, and then writes to Dear Abby or something like that. In any case, spends the whole weekend ruminating about what did he mean by that. And then the final pane or whatever shows the guy, and he says, I wonder what she meant by that. Let's go play basketball. And goes off and does something distracting, which is actually what Nolan Hoeksema would suggest is the thing to overcome excessive rumination, is to do things that are distracting and take your mind away from it. Well, I want to get back to the question of whether or not depression is on the increase. And this is if you can see it, a constructed graph that is really just kind of made to look like a series of graphs from a research study. In these studies, what they did was to ask people the question, did you ever have a period during your life when you met these criteria over the course of 2 weeks, and gave them the criteria for depression. And then the further question is, if you ever had an episode like this, when did it first begin? When in your life did it first begin? And this is a graph across the lifetime. At the bottom, it should say 20, 40, 60, 80 rather than 2, 4, 6, 8. And the side is showing sort of the percentage of people who report having an episode at a particular point in time. And if you can follow me on this, if you ask people who were born, who are now, say, in their 70s, 60s or 70s, when did you ever have an episode and when was it? They will report that they had a relatively few occurrences early on. Later in life they had a little bit more, and maybe a total accumulation of somewhere around 2% of them report having an episode sometime in their life. Now you take people born a decade or so later in their 60s, and you ask them the same question, and they report some early onset, some onsets in the 20s, some onsets in the 30s, but they end up much higher with a total of maybe 4%. Now ask people the same question who are in their 40s, and you get them by the time they're 40 going up to something more like 5%, and you ask people who are in their 20s, and you've got them up to a very high percent much earlier in life. The researcher Peter Lewinson, who has recently done some studies of the incidence of depression in high school students, he's surveyed a number of high schools in Oregon, and all students who met a certain criterion on a paper and pencil measure were then interviewed for clinical depression, and he's finding 20% of high school students have either have currently or have had an episode of major depression. So if you graphed that, it would be up off this graph somewhere up there. Now, what this seems to be showing is that the more recently your birth, the higher lifetime risk you have for an episode of depression. And this is one graph. The same study was replicated in other parts of the world, in Taiwan, in Lebanon, I think it was, and in Puerto Rico. This happened to be researchers who replicated it there, and they found essentially the same kind of pattern. It might not look exactly like this, but you get the same sequence of more and more elevated, accelerated graph lines. So the question is, what's going on here? Note that the particular form of the questioning may have something to do with it. Any thoughts on what might explain this, other than depression is getting more and more prominent?
Couldn't it be that when you're younger, like in your 20s, usually people have depression and like they feel down more, and you're younger, and then as you get older you kind of forget about that when you're 20, that when you were 20 what you felt, and you have a different perspective.
So it could be just a reporting differences. Younger people may be more ready to report it, may be more sensitive to identifying it, and it could be part of what you're suggesting maybe that there's a cohort effect. That is, that people who were born 50 or 60 years ago may not have recognized it also when they had it. Any other confounds that you can think of?
Maybe we're just becoming more obvious, like people are just beginning to see it more, so they diagnose it easier, whereas in the past it wasn't something you would admit to. So just because they see it more now doesn't mean that they would admit that they had it back then.
Right. So it may be admitting to it and recognizing it. Yeah, and that certainly could be the factor. I can imagine an older person saying, well, yeah, I had a rough time when I was in my 30s, but no, I wasn't really depressed. I also remember an older psychiatrist saying that he used to have patients who would come in who were referred to him, and they would say, doctor, I've been having trouble sleeping and I've lost my appetite and lost interest in things. And he'd say, oh, you're depressed. And he said, these days, patients come in and say, doctor, I'm depressed. And he says, oh, have you lost your appetite? Have you, are you having difficulty sleeping, etc.? That people are much more likely to self-diagnose and to identify the problem as depression. It's also possible that there's differential attrition. People who are depressed, depression is a negative prognostic factor. If you have heart disease or such, you are more likely to have a second heart attack if you're depressed, for example. So it could be that some of the people who had early depressions are no longer around to be in the study by the time of 70 or 80 or such. I've heard arguments on both sides. One saying it's all artifact, it's all due to the nature of the retrospective questioning, etc. But others arguing that you can't explain it all away by artifacts. And there do seem to be other sources of data that are suggesting that depression is on the increase. We'll talk a couple times in the course about Martin Seligman. Seligman wrote an article where he argued that it's on the increase in our society because of our stress on individualism and individual responsibility. You're to blame if something goes wrong in your life, and the decline in sort of the community, sources of community response. We no longer, contrast the families today to families of 50 years ago or 100 years ago. We no longer have the extended, interconnected families. Families tend to be split up. People move around the country. We have many more single-parent families. We have fewer children in families. So there's less of a sense of others and family members who you can rely on for support. We have less of a sense of community, whereas you used to grow up in a small town or a rural area or even a neighborhood in a large city in the U.S., and you knew all the families of the people who you went to school with. And again, if you had problems in school, the school sort of saw it as their problem, and the community saw it as their problem, maybe the church group, et cetera, et cetera. And his argument is we don't have these sources of community that we used to have, and again, the result is that the responsibility all gets put on the person, so that the child is now sort of to blame, and it's the child who has the problem, and the child who may accept that sense, and that produces a depression proneness, a readiness to accept that bad things that happen to you are your fault, and you're not going to be able to change, and you're going to be helpless, etc. So one can make the argument that our changing society is producing a greater psychological vulnerability, a greater psychological diathesis for depression. Any comments or questions on that whole issue? No? All right. I want to begin talking a bit about models and theories about depression. And to begin with, depression has certainly been studied from the biological perspective and looking at the biological contributions and biological underpinnings of depression. And this has been looked at I'm sure one could add to this list, but these are sort of the primary ways in which depression has been thought about. And the first is to look at neurotransmitters and deficiencies in neurotransmitters. These days, norepinephrine and serotonin are the most likely identified neurotransmitters associated with depression. And this is kind of a research strategy that kind of argues backwards from treatments that are effective. Medications that are effective tend to be medications that increase levels of norepinephrine or serotonin. And I'll talk a little bit later about medications, but these days the modern antidepressants are SSRIs, selective serotonin reuptake inhibitors. That is, they keep serotonin from being taken back up into the initial cell and therefore increase the density of serotonin in the synapse. Or another class of drug are the SNRIs, serotonin and norepinephrine reuptake inhibitors, so that you have some drugs that inhibit the reuptake of both. And so it is by looking at what are the mechanisms, studying the mechanisms by which the medications seem to have their effect, that leads to hypotheses about the nature of the depression. And it leads to other kinds of studies of the biochemistry of people who are depressed, etc. There's a little bit, no one would, there's a bit of a problem with this logic. It's sort of like asserting that headaches are due to aspirin deficiency. And no one would really argue that, but it's almost the same kind of research strategy, but it takes then other lines of evidence and other lines of study to support the idea that it's particular neurotransmitters. Others argue that neurotransmitters are either a cause or an effect of endocrine changes, and there are also endocrine models of the nature of depression. And I mentioned already, and this has become a new area with a lot of interesting implications and promise in recent years, and that's the idea of biological rhythms being affected. Depression does have diurnal variation, that is, during the course of 24 hours. Melancholic depressions are identified in part by being worse in the morning. Studies of sleep cycles and sleep dysfunctions identify changes in diurnal variations. People who suffer from depression, you can if you measure minor temperature changes. We all go through mild temperature cycles in 24 hours. The temperature cycle of depressed people is off by a couple of hours. The nature of sleep changes in severe depressions. One of the closest things we have to a biological marker is change in the sleep sequence during the night. Typically, when people fall asleep, they go into a deep sleep, and then about 45 minutes later go into their first dreaming period of rapid eye movements, REM sleep cycle. People who are depressed go virtually immediately into REM sleep, and you get this decreased REM latency. It's referred to REM being rapid eye movement latency. within 10 minutes, people are having REM sleep, which means they're missing the first big cycle of deep, more perhaps restorative sleep. Again, it's a part of the biological cycle that seems to be disrupted. This is evidence of disruption. So this is starting to be, the implications of this idea are starting to be applied to intervention and treatment. Ellen Frank at Western Psychiatric Institute in Pittsburgh has developed an intervention program based on this that refers to as social rhythm therapy, where the idea is, and this is particularly for people who suffer from manic depressive disorder, from bipolar disorder, is to try to regularize your routine. Get up at the same time every day, go to sleep at the same time every day, try to eat at regular, predictable times, try to get exercise at regular, particular times, and use these various rhythms of activities to try to put your rhythms in order and try not to disrupt them. There's some research that suggests that it is that episodes, people subject to bipolar disorder may develop episodes when when these rhythms are disrupted in various ways. You stay up late and miss a lot of sleep. That may be associated with one of the things that seems to precipitate an episode. Steve Ilardi now has a similar kind of program, also for bipolar patients, I believe, that stresses sort of the idea that our modern life has us dissociated from all of the things that used to keep us on regular cycles of various sorts. And so his program similarly has to do with doing things at regular points during the day, getting exercise and outdoor exposure and other such things. Actually mentioned earlier, from this biological perspective, there is evidence of a genetic component to depression. If you, amongst monozygotic twins, that is, if you have 100% of genetics in common, if one twin has a disorder, a co-twin has a 40%. If one twin has unipolar depression, the co-twin has a 40% chance of also developing the disorder. If one twin has a bipolar disorder, the co-twin has a 72% chance. And if they're dizygotic and therefore only share half the genetics in common, it's 11 and 14%. And these figures suggest that there is a clear genetic risk, but also that there are other components, there are environmental influences that influence whether or not people will have the disorder or not. But particularly for bipolar disorder, it does fairly clearly run in families, and if you have first-degree relatives with bipolar disorder, you have an increased risk for developing the disorder. There have also been some various efforts to develop biological markers for depression. These include looking for the byproducts of neurotransmitters, byproducts of norepinephrine and serotonin in urine, blood, or spinal fluid. And this has had some correlation, but it's not a strong enough indicator to consider it really a diagnostic marker. The dexamethasone suppression test has to do with giving a medication that suppresses cortisol production, except in depressed people. They may not suppress their cortisol production, which is also already, the assumption is that their cortisol production is already stressed, maxed out. And that was seen as having a great deal of promise as being a biological marker. Again, now it's seen as a correlate. It occurs in some patients, not in all, and it occurs in some people who are not depressed. In some ways, the best has to do with sleep architecture. That is the structure of sleep during the night, and I mentioned reduced REM latency as being a primary candidate here. It has a number of interesting features. If you start someone on a medication for depression, for a medication to take effect, it often takes a week or 2 weeks to have its effect. You have to get the blood level up to a certain level, criterion of some sort. But if the medication is going to work, REM latency will change before you see a clinical response. Before the person starts to feel better, their sleep will change and improve. And change in the sleep will predict who's going to have a positive response to the medication. Now, that's not a practical thing to do. It's very expensive and distracting to have people come in and spend their nights wired up in a sleep lab. So you're not going to do that with everybody who you're going to give medication to. But it's an interesting indicator of a biological response prior to a more widespread clinical response. In general, reduced REM latency also responds to treatment. Give the person medication. If the medication is effective, the person's sleep will improve. Give the person psychotherapy, and their sleep architecture will improve as they improve in psychotherapy. So it's a marker that responds to treatments, whether they're psychological or biological treatments. Medications are a primary treatment modality for depression, and we've had there are several generations of medications. The early ones were the tricyclic antidepressants, the TCAs. Elavil is a typical one of those. They're still used in some instances, but they tend to have a lot of side effects, and I'll talk about the side effects in a moment. Actually, tricyclics, I didn't put in there were quadricyclics that were sort of the next development. But then the more modern drugs are the SSRIs, such as Prozac, and the serotonin and norepinephrine reuptake inhibitors like Effexor. There are some drugs that work just on the norepinephrine system, and then there are some other drugs that actually work on different neurotransmitters that also seem to be effective. I recently read a very extensive review of the effectiveness of medications, and what they find is essentially all of these medications are essentially equivalent in effectiveness. That is, there are virtually no studies that they could find internationally that demonstrated one medication more effective than the other. The big difference is in the side effects and the side effect profiles. So the more modern drugs are equally effective but don't have a lot of the side effects. And for the older drugs, tremor, slurring of words, tingling sensations, problems with balance, heart palpitations, rapid heartbeat, sweating, urinary retention, drops in blood pressure, and even visual hallucinations were side effects. You get some of those side effects with the SSRIs, but they're much milder and much less frequent. The MAOIs are a different class of drugs, monoamine oxidase inhibitors. They tend to be used with the atypical form, but they're very problematic because they interact with other medications. You should not take them with other antidepressants. And you have to avoid the chemical tyramine. I have it in my notes triamine, but I'm pretty sure it's tyramine. Tyramine occurs in fermented foods, cheese, wine, aged foods, pickled foods, and also in things like chocolate. So you have to avoid chocolate if you're on if you're on MAOIs, and not avoiding these things can lead to severe blood pressure increases and even intracranial bleeding. And it doesn't take too much. I had a patient once who tried to commit suicide. She was on an MAOI and she ate large quantities of chocolate, so it was suicide by chocolate, and produced a hypertensive crisis, and had to, a friend had to call an ambulance, and they rescued her in the hospital. I should mention also, in this context, an herbal remedy for depression is St. John's wort. And St. John's wort has been studied, and actually I've seen 2 reviews. One has said that it's effective, and one said it really isn't effective. So I don't know what to say about its effectiveness, but it is probably a naturally occurring MAOI. So people think that, oh, this is herbal, so it's safe for me to take with anything, and I can just add it to my regular medication, and maybe it'll add something to it. But you really don't want to do that, because if you're taking another antidepressant, and you add an MAOI to it, you may get negative interactions between the drugs, and you may also have interactions with regard to some of these other chemicals. I don't have on this slide, but for bipolar disorder, lithium salts. Lithium is a naturally occurring element, and there are lithium salts. One of the ways in which lithium was discovered as a treatment for bipolar disorder was by epidemiological studies that found that there were parts of the country where bipolar disorder was less frequent than in other parts, and they went searching for what is characteristic of these parts of the country. It turned out to be parts of the country that had high concentrations of lithium salts in the water. And that was one of the clues that started people experimenting with lithium salts. They seem to help to adjust cell membranes in the nervous system so that they are regulated, and they keep people from having the swings of bipolar disorder. Anticonvulsants are also used. Yeah, lithium salts and anticonvulsants are used in the treatment of bipolar disorder. They both tend to regulate mood. To talk a little bit about electroconvulsive therapy that's also used. This is the treatment that involves putting an electric current through the brain, put 2 electrodes on the person's head, and turn on a high voltage, low amperage current for brief periods of time, and it sets off a grand mal seizure. The origins of this come from, in part, from an incorrect observation that people who suffered from grand mal seizures didn't seem to suffer from severe psychiatric disorders. It's not true, but somebody made that observation and thought that maybe the seizure keeps people from having schizophrenia or severe depression. And early experiments and treatments following this idea used insulin shock therapy, inducing grand mal seizures with insulin, which carries with it some dangers of various sorts. Then somebody actually observed in stockyards. Stockyards were using shocks to the head of cattle to knock the cattle out before they were slaughtered, before they were killed, and therefore noticed that and the cattle often had grand mal seizures when they were knocked out with. So someone decided, gee, maybe this is an alternative way of inducing grand mal seizures in humans. I actually read the story of the first person who volunteered to say, well, yeah, you can try it on me. Any case, it is a procedure that's been somewhat controversial. The big question has to do with long-term consequences and memory problems that may result from ECT treatments. They are used, there's a different method these days. It used to be that they were bilateral placements, one on each side of the head. Now they do unilateral placements, and fewer side effects occur, less memory loss. I actually, I've attended ECT sessions, watched patients be given ECT, and then also tested them psychologically for their memory afterwards. And first of all, the way in which it's done, they usually will have the person lie down on the table and put the electrodes on, and then give the person a muscle relaxant so that they don't hurt themselves when they're seizing and having the grand mal seizure, and typically have 2 or 3 people, this is at least the way it used to be done, they would have 3 or 4 aides stand around, one holding one arm, the other arm, the legs, again to protect the person from hurting themselves, and somebody holding a tongue suppressor so they don't bite their tongue. And then the psychiatrists, when I was watching it, would throw the switch and they induce the grand mal seizure. Sometimes if it didn't, they'd turn it up a little bit and throw the switch again. When I tested people, I would test them before they got the ECT and get normal short-term memory. If you ask people, digit span is, I read you a sequence of digits and you say them back to me from memory, and we see how long a string of digits. And most people can remember 7 or 5 to 7, 5 to 9 forward, and maybe 4 to 6 backwards. That's a typical normal. And what I would get was an hour or 2 after ECT. It takes a while to recover from it. So a couple hours later, you'd get a very marked deficit. People would go from remembering 7 to being able to remember 3. You tested them again the next day, they might be back up to 7. But if they were getting a series, which is typical, you get a series of ECT treatments, the recovery would not be as complete. And again, this is relatively short term. And this has been very controversial, whether there is a long-term memory loss or not. The most recent article, which I saw just came out within the last month or so, was a review of ECT as it is delivered in a variety of settings. And what they found was that it's not delivered well in many settings. That is, it doesn't follow the most up-to-date recommended protocols for placement of electrodes, etc. And they were finding that people did have complaints of relatively of memory loss, permanent memory loss, well after they had their treatments. It is still approved. There was American Psychiatric Association did a review a while ago and concluded that it should be kept in the armamentarium of treatments. Typically is used for more severe depressions and depressions that don't respond to other forms of treatment. I've said I've seen it given. I've also seen it, some people have fairly dramatic recoveries from it. Remember one elderly patient at UCLA who had not been responsive to medications, who'd had a number of episodes of depression over his lifetime, but at age 76, I think they were reluctant to give him ECT, which had worked in the past, just because of his age, and so had tried all sorts of other treatments and had absolutely no response from the other treatments, and finally decided to go ahead with ECT, and he was released in 3 or 4 days after a couple of sessions of ECT. Just had a complete remission of his depression. So it's certainly worked for some people, but it continues to be somewhat questionable in terms of long-term effects.
How does it work, though? I mean, what's the reasoning for why it works? Why shocking? That's
a very good question. The question is why does it work? How does it work? Nobody really has a good theory. There are various theories about what it might do. That it might be sort of a shock to the immune system or to the neurotransmitter system in some ways. That
resets it or something?
Pardon?
Like it resets your neurotransmitters or something? Or
yeah, or that it's recruiting your immune system to respond to stress, and that's producing an effect. That's kind of what the psychological ideas would suggest, is that you're putting a big stress on the body, and that you're getting the person to kind of fight back and try to recover, to try to regain their consciousness, if nothing else, afterwards, and that you may be kind of recruiting efforts to feel better in general. I'll talk later about a patient who tried to commit suicide by jumping out a window and broke lots of bones but survived it, and also had a remission of their depression, and always thought of it as kind of a do-it-yourself shock treatment, but here a physical shock rather than an electric shock. And I don't know if that's an appropriate analogy, but it may be that it's just somehow again, recruiting efforts at regaining one's health and well-being. But I'm sure there are also more biological models of what it might be doing, again, to endocrine systems or neurotransmitter systems or whatever. Let me start talking about some of the psychological theories. Psychodynamic models. Freud talked about unresolved grief, anger turned inward. There tends not to be a lot of research that supports the anger turned inward depressed people may often be angry, but it's not turned inward necessarily. Other ideas have to do with failure to internalize standards, so being subject to external evaluation and being therefore very sensitive to external evaluation. One of the outcrops of that kind of idea is research that has to do with what are referred to as sociotropic versus autonomous personalities. The idea is that people's self-esteem may be based on various sorts of things, and typically there are two major sources for one's self-esteem. One is social relationships, other people, the esteem of other people. And people who tend to rely on the good relationships with other people for their self-esteem are referred to as sociotropic. They're attracted to other people. They orient toward people in their environment. Autonomous people are more achievement-oriented and look to accomplishments and achievements and reaching goals for their self-esteem. And these days, these are thought of as personality dimensions and are essentially two dimensions, two separate, slightly correlated, negatively correlated, but tend to be, you can be both sociotropic and autonomous, or you can be neither. But they tend to be often thought of as your one type or another. Sociotropic people are more vulnerable to developing depression from interpersonal loss or breakup or interpersonal distress of some sort. Autonomous people are more likely to develop depression following some blow to their achievement goals, loss of a job, or some such thing. And there's some research that finds that if you measure sociotropy and autonomy before people become depressed, that you can identify which type of precipitant is more likely to have occurred when the person becomes depressed. Now, this is difficult research because you're trying to do a prediction, and often it's actually done as post-diction. You're measuring it after the fact. And it has some problems, like it may be that sociotropy versus autonomy has to do with how you interpret an event. If you get bad grades one semester, is that a sociotropic or an autonomous loss? If you're a sociotropic person, you may say essentially, what are my parents going to say? I'm disappointing them, they're going to be unhappy with me. Whereas if you're an autonomous person, you're going to say, this is not going to help me get into graduate school or whatever my other future goals. So different people may be interpreting the same event sociotropically or autonomously. And what you really need to be able to do to verify this theory is to find people who are sociotropic and who have autonomous negative life events and who therefore don't become depressed, and autonomous people who have sociotropic life events and don't become depressed, as well as those who, if it's consistent with their orientation, do become depressed. Interpersonal therapy kind of comes out of this model. It has a kind of psychodynamic background and focuses on repairs to interpersonal problems and tries to identify what kind of interpersonal disruption is occurring in a particular individual's life, and try to deal with solving the interpersonal problem. Peter Lewinson is best known as the kind of originator of the behavioral approach, and Lewinson hypothesizes that the basis for depression, his phrase is, a loss or lack of response-contingent reinforcement. And this is kind of going back to animal models and suggesting that if you lose a major source of reinforcement in your life, your behavior deteriorates. And he would say essentially that if you lose a job, or the death of a loved one, or the breakup with a boyfriend or girlfriend or something like that, represents a loss of a major source of reinforcement. Our lives tend to be organized around different sources of reinforcement, and losing a major source may have implications all over the place. One of the things that happens in depression is we lose perhaps one source of reinforcement, but lots of different behaviors deteriorate. There's an article about this that sort of made the analogy or posed the case. You break up with a boyfriend or girlfriend and you don't feel like eating anymore. Why would that connection be there? Well, the argument was perhaps you used to like to go to the movies with that person. So being with that person was reinforcing, going to the movies with them was reinforcing, and that produced all sorts of behaviors. Like in the morning, you enjoyed sitting and reading the paper and checking out what movies were around for the weekend while you had your breakfast. Person's not there, nobody to go to the movies with, no reason to look at the movies. Breakfast doesn't taste good anymore. You don't have the motivation to enjoy your breakfast. And the argument is that you get those kinds of ripple effects or chain effects when you lose reinforcement. And the further kind of elaboration of this is that there are three primary ways in which this may occur, this loss or lack of response contingent positive reinforcement. One is that the environment changes, or the environment is lacking the reinforcement. Something changes in your environment, again, you lose a job or you lose a relationship. And so the strategy there would be to try to enrich the environment, get the person back into an environment, find somebody else to go to the movies with, start dating again, whatever. The second reason that a person might have a loss or lack of response contingent reinforcement is that they don't have the social skills or other skills to obtain the required or necessary reinforcement. Maybe they don't have the job skills to get another job or to get a good job. Maybe they don't have the interpersonal skills to establish good new interpersonal relationships. So a therapy strategy to match that, if that's the person's circumstances, to try to do some skill training of some sort. And the third cause from Lewinson's perspective is interfering anxiety. Social anxiety may prevent some people from appreciating the positive feedback they get from others, or potentially could get from others, so that they're not participating in a full social life to get the reinforcement that they need. So again, dealing with the anxiety, some form of relaxation training, desensitization, cognitive intervention would help the person to be able to access a more rewarding environment. A second kind of behavioral approach is the skill deficit sort of idea. One of the originators of behavioral treatment, Joseph Wolpe, argued that whereas anxiety had to do with conditioned emotional anxiety or conditioned anxiety, that depression tended to have to be based on social skill deficits and inability to establish or maintain good interpersonal relationships. And so the primary strategy that Wolpe employed was social skill training. Problem solving is a slightly different idea. There is some research that suggests that people who are depressed or tend toward depression tend to be poor problem solvers. They're not likely to see, to construe something that's not going right in their life as a problem to be solved and to approach it by saying, okay, now what can I do to solve this problem? They're more likely to view things as terrible things that are going on that I can't do anything about and I can scarcely bear. My boss hates me and I can't get a different job. I'm dependent on this job, so I'm just going to have to endure it. Rather than, what can I do to improve my relationship with my boss? How can I get him to view me more positively, etc.? Or does he really hate me, or am I just misinterpreting things? Problem-solving interventions teach people how to identify and define problems and how to go about solving them, generate lists of possible strategies, go through them and evaluate them for their effectiveness, etc. And marital therapy is based on a similar idea. Marital therapy interventions are based on the idea that many depressions originate in poor marital relationships and communications, and that this may be central to a lot of depressions, and thus marital therapy interventions have been suggested and are used. And these often have to do with communication problems. There have been some interesting studies that look at communications between people, between couples in particular, and what the intent of one person's communication may be and how it is received by the other person, and how what it may be intended to be a constructive suggestion is taken as a criticism and such. I think it was Gerald Patterson who had couples discuss problematic aspects of their lives and gave them poker chips. And if somebody said something that you liked and made you feel good, you gave them, a green poker chip. And if they said something that made you feel bad or that you didn't like, you could give them a red poker chip. While you were having your discussion, the idea being that often we don't verbalize, you don't usually say, gee, I like that you said that. We just feel good or feel bad. And so he was trying to get into the open, into view, if you will, into clear communication, how the person was feeling and responding. And I've heard people who have done this with couples talk about, one person says something, somebody says they're going back and forth, and somebody gives them a red chip, and you're giving me a red chip for that? Here's 2 red chips for giving me that red chip. And they'll sort of get into chip fights, but it clarifies how people are feeling and then gets them to be explaining, well, I felt that way because I took it this way, and I didn't really mean it that way, and the emotional consequences of their communication becomes clarified. And therapies like that, interventions like that for marriages have been found to be effective treatments for depression. It is typical in marital situations that one spouse is depressed in the relationship, more frequently the wife, and that there's an imbalance in sort of power in the relationship, and rebalancing the relationship often can lead to remission of the depression. And there are actually studies of marital relationships where other forms of treatment are used, medication, for example, that show that when the person remits from their depression or recovers from the depression, that the marital relationship tends to improve or respond as well. So there is a relationship kind of in both directions. Well, I want to talk about some other theories about Seligman's helplessness theory and actually my own self-management therapy, Aaron Beck and cognitive therapy, but we'll do that next time.